Good evening, everyone. My name is Mauricio Kfuri. I have the honor to moderate the webinar tonight when we're going to talk about medial knee arthritis, medial knee pain, and discuss with you indications for osteotomies and unicompartmental knee replacements. The reason why we decided to present this topic to you is because when somebody comes to clinic with medial knee pain, there is a large and broad spectrum of clinical presentations with different image studies that you can identify. In this image, or in this slide, you can see 3 different patients with medial knee pain. And the 3 of them have different profiles, different levels of activities, different group ages, but all of them have the same symptoms. And today, we hope that we can present to you some concepts that can help you to decide which patients could be good candidates for osteotomies, which patients could be good candidates for replacements. So this is who I am. Mauricio Kfuri is my name. I am an associate professor at the University of Missouri in Columbia in the United States. I was trained and lived in practice for many years in Brazil. I also spent time in Germany doing a postdoc training, and currently I work at the University of Missouri. I have the honor to have 2 outstanding faculties joining me tonight. One is Professor Robert Teich, who is Professor Emeritus at Wayne State University in Detroit, Michigan. Professor Teich is an emeritus professor, and he was recruited to build the Center for Athletic Medicine at the Henry Ford Hospital. And over the years, he became the physician for the NFL Detroit Lions, MLB Baseball League Detroit Tigers, NBA Detroit Pistons, among other commitments as professor at the Wayne University. Also, it's important and relevant to say that he has been involved with AO Foundation since 1978, and he was one of the founding members of AO North America. It's a great honor to have Dr. Teich here tonight, and also important to say that he is an authority in patellofemoral disorders, so it's a great honor. Then I have also my dear friend, Professor Stefan Schroeter, who happens to be a person I met years ago in one of those many courses that we have attended together. He was trained at the BG Trauma Center in Tübingen in Germany and moved as head of the department at Level 1 Trauma Center in Siegen in Germany, where I had the opportunity to visit with himself and his family last year. He is one of the brightest individuals I know in the area of the correction of deformities. And with him, we have shared in many opportunities as well. And I have learned so many things from him. And I hope that you all can take the opportunity to enjoy and learn from Professor Schroeter tonight. So these are our disclosures. There is nothing relevant and that could be important to mention for the purpose of this webinar. Also, it's important to say that AO North America is an independent, no-profit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries, does not endorse nor promote the use of any product, service of commercial entities, and equipment used in this course or for demonstration and teaching purpose with the intent to enhance the learning experience. About Zoom, all microphones should be muted and video cameras should be turned off. You are invited to send all your questions using the QA box in the Zoom. And the moderator will review your questions and we'll try to introduce your questions to the faculty. So we may try to answer as many questions as we can. And I promise you, in case we don't have enough time to answer all questions, I promise to reach out back to you and send you answers via email if necessary. We would like to make this a very informal environment for you. We'd like you to feel comfortable and ask the questions you'd like to. So for tonight, we designed this webinar thinking about, okay, what should be relevant when we talk about medial knee pain, medial knee arthritis, and is there a way to determine which patients should be those that should receive osteotomies, which patients should be those that should undergo a knee replacement, a unicompartmental knee replacement? In order to answer those questions, we aim to talk with you about the importance of the alignment of the lower limb. Also talk to you about osteotomies, which are procedures aimed to preserve the joint, and talk to you about joint replacements that are procedures that, when well indicated, they could be completely life-changing to the individuals. So this is our brief agenda, so you can have a good understanding about, we are going to be together for about 65 minutes. And during this time, we would like to take the opportunity to share everything possible to address topics like lower limb alignment, varus knees, what kinds of treatments you can offer for individuals with varus knees, and also individuals with medial knee pain. So I would like to invite you to look at the All North America homepage. There, you're going to see multiple educational opportunities for you. I would like specifically to call your attention for this event in February, which is happening in Florida, and I have the opportunity to chair this course as well. It's going to be an outstanding opportunity for education. It's an advanced course for the knee. We're going to cover all kinds of ligament reconstruction during this practical course with artificial models. And I really invite you to visit the webpage of Your North America if you're interested to have a review on the topics of multi-ligament knee injuries and deformities around the knee. Thank you very much. With this, I would like to stop sharing, and I will hand over to my colleague, Professor Schroeter.
So, good evening and good morning from my side. Thank you very much for the kind introduction. So I will start immediately with my presentation, lower limb alignment in the coronal plane. So my learning objectives are at the end of my presentation, you should be able to describe the different axes and planes, describe the difference between anatomical and mechanical axis, and define the joint angles at the lower limb. It sounds at first a little bit simple, but it is not. So you will see it immediately. So topics are principles of geometry in different planes. So we have three planes, which probably all of you know: the coronal plane, sagittal plane, and axial plane. But what are we doing and thinking about if we talk about deformity corrections? We have in all these planes different possibilities, and we called it 6 degrees of freedom. So regarding translation, we have 3 degrees of freedom in direction of the rotational axis, which are perpendicular to the planes, and a rotation at this axis, and there are additionally 3 degrees of freedom around the axis. So come to the first plane, the axial plane. On the axial plane, we have the longitudinal axis, and in this axis, there are deformities in movement possible. The rotation, internal and external torsional deformities, or correction regarding rotation after osteotomies, and translation, shortening or lengthening of the limb. In the sagittal plane, we have the horizontal axis and deformities movement. Rotation ends up in anticurvation and recurvation, and translation means medial or lateral translation. And then we have the coronal plane, which talking today. There we have the possible rotation of the axis, and that ends up with varus or valgus correction or the deformity, and the translation anterior and posterior. That is very important to understand these principles of 6 degree of freedom. Come to correct X-ray, because that is the prerequisite that we are able to describe deformities and plan a correction. We need a full weight-bearing long leg X-ray, and it's sometimes a little bit a challenge to get this X-rays from your X-ray department or your radiologist. So you have to take care that, in principle, the patella should look forward, that you have the perfect X-ray, which you see on the right side of my slide. But it's not always the same story to get an X-ray, because, for example, if you have a case after several patella dislocations, and you go again for looking at that the patella should be in center of the knee, it's not correct, because you see there the patella is centered, and probably you think it is okay, the X-ray, but it is not, because the patella is, in this case, should be lateralized because of the several patella dislocations. The knee AP is not orientated at the patella. So if you have a case of the several patella dislocation, you should be aware. So to know a little bit more about the criteria, I have this slide that you can think about more about the quality criteria of the long lateral weight bearing X-ray. So at first, the patella should look forward, but not in all cases, because in special cases, it is not forward. Then the next point is if you have a normal torsion of the femur. That is very important to know. If you have a normal torsion, you should see an AP projection, the trochanter minor should be visible. And the proximal tibiofibular joint should be 1/3 behind the tibia. That is a very important part to analyze the X-ray, because even if you have a torsional problem at the femur, if you go for the knee joint AP, it should be 1/3 behind. And then it's like shape of femur of the femur condyle should look normal. If you compare the left X-ray to the right X-ray, it looks completely different. And regarding the shape, and sometimes if you mention to the radiological department patella look should forward, you will get some X-ray which are highly internally rotated, and then the shape of the condyle will change. And please do not start to plan or analyze with this wrong X-rays. So, and the next problem is that in a lot of radiological departments, that is not one part, the X-ray. So it's a kind of stitching, and you should be aware that there could be problems with the stitchings. And if this crossing point or in our department, you see these crossing points not completely superimposed, then it's in an oblique way. They stitch the X-ray, and it's an automatic process in the software, and sometimes they do not completely right. And it's obvious if you put them together in an oblique way, you will have an effect on the analysis of the X-ray. So you should be aware of these technical problems. Come to the axis in the coronal plane. So we analyze deformities. We have two axes, anatomical and mechanical axis. Regarding deformity corrections in the degenerative OA, we usually not plan with the anatomical axis, but you should be aware on that. The anatomic axis of the femur is in line of the femur shaft and of the tibia. If we go for post-traumatic correction, for example, in the middle of the shaft, and there you have a huge deformity, you should plan with the anatomical axis according to the Cora method, but it is not a topic of today. So we use in this part the mechanical axis, which is the center of the hip to the center of the knee regarding femur, and the tibia is the center of the knee and the center of the ankle. What are the joint angles? Drew Paley from Baltimore, he described in a great book, I called it the Bible of Deformities, different joint angles. And we have the first one, which is in the proximal part. It's a mechanical lateral proximal femur angle with a norm value between 85 and 95 degrees. And then at the distal femur, the mechanical lateral distal femur angle, the norm values are again between 85 and 90. And MPTA, usually if you have not a huge post-traumatic deformity, the mechanical and anatomical medial proximal femur angle is the same, so norm value between 85 and 9. And the lateral distal tibia angle, and there the norm value is between 86 and 92. And then we can measure the mechanical tibiofemoral angle, which describes the varus or valgus deformity, and is the angle between the mechanical and anatomical axis. And we have additionally the joint line convergence angle, which is the angle between the tangents at the distal femur and the proximal tibia. So at the end, I would like to mention digital planning, because meanwhile, we're very proud on it that we are able to develop, together with the software company, the first AO Foundation approved software tool to analyze deformity in the coronal plane with an automatic process. If you have a long full weighting X-ray, you can use it from your PAC system, or for each other picture is possible too. And then you go for a segmentation process, just push the button to the AO tool, and then the landmarks will be detected automatically, and you just have to adjust a little bit, which speed up the process of deformity analysis in an amazing way, because you're able to analyze and plan the whole correction in just 2 or 3 minutes, and you can include it in your outpatient clinic and present it to your patient. This is a huge advantage meanwhile. And the software, immediately you see it on the left side, offers you the deformity analysis. The colors are according the traffic lights. So if it is green, it's inside the norm values. If it's red, it's outside, and yellow, it's a little bit on the border. And the software gives you a recommendation what you should do for correction. And if you have a huge deformity in the MPTA, they recommend the open wedge HDO, because the MPTA is below the norm values. And then the software suggests you a cut on the proximal tibia, and with the hinge point at the tip of the fibula, and then you can adjust the cut according to your personal favor. It depends on the surgeon. You use different implants, and so you can adjust it, and you can adjust the planned correction on which correction you would like to end up, and then the software do it automatically. So at the end you can put implants in if you would like to do that, but I guess that is not very interesting for you to see there at the moment different implants. So my take-home message is for you. Also, deformity correction in the coronal plane is the majority. Knowledge of all planes is mandatory, that you do the right thing in the right case. So take care on perfect X-ray, because that is the prerequisite to get the right deformity analysis, and analysis of the deformity according to Paley is, in my opinion, recommended. Analysis of the, and digital deformity and planning software is AO Foundation approved meanwhile, so it's a very valuable tool, and I really can recommend it. So thank you very much for your attention.
Thank you very much, Dr. Schroeder. What I would like to say, as Professor Teich is going to share his screen now, the take-home message that's critical if you're dealing with somebody with knee pain and you are trying to evaluate various deformity, it's critical to have a good X-ray that shows the alignment of the lower limb, and that you use any method that you're familiar with to obtain the joint orientation angles, because this is going to guide you very much about where the deformity is and where's the problem. So with that, let's go to Professor Teich, who is going to talk to us about indications for high tibia valgus producing osteotomy. Thank you very much for your attendance to this meeting tonight.
Thank you very much. We're talking about the varus knee and observations on high tibial osteotomy. The indications for knee osteotomy or for medial unicompartmental arthroplasty. There is no absolute indication for knee osteotomy, and there is no absolute indication for unicompartmental osteotomy. The outcome of both depends on the final limb alignment. So what do we know about alignment? Well, Stefan has just been wonderful, but our current convention defines limb alignment based on the location of the mechanical axis. In 1878, Michelitz defined this weight-bearing line, and he stated in 1878, it is clear that in every normal limb, owing to the usual bearing of the weight of the body, an equal portion of it is borne upon both halves of the knee joint. So this is the Michelitz line, or the mechanical axis. Now, Fick in 1911 showed the mechanical axis is tilted with a angle between the joint horizontal and the distal femur at 87 degrees. Freeman published this in 1970, showing that the mechanical axis is 3 degrees off the vertical. And Austin, also in 1970, showed the mechanical axis is 3 degrees off of the vertical. with 87 degrees on the medial proximal tibia and 87 degrees on the distal lateral femur. And of course, with 3 degrees of inclination, it's 87 degrees between the ground and the tibial shaft. So the normal alignment, because the hips are wider than the feet, the mechanical axis tilts 3 degrees medially with a horizontal joint line. So the tibial plateau is tilted down 3 degrees on the medial side. Now, if the mechanical axis is not through the center of the knee, then you need to find the deformity, and these numbers will allow it. And you can start by just remembering 3 degrees tilt and 87 degrees on the medial proximal tibia. McKay's diagram is what you also need to remember. McKay's diagram shows here the mechanical axis listed as A, but the total muscle forces with the total vectors going across the joint are the related to muscle he calls L, and the total body weight or body mass he calls P. So the resultant vector is a combination of the muscles plus the weights. The resultant vector is the combination of lateral muscle pull and body weight. Normally, this falls near the medial tibial spine, but if you have too much weight or too little muscle, it's shifted medially out of alignment. We overload the medial compartment, often getting this pattern of radiographic increased density. So the goal of osteotomy is to move the resultant vector to unload the overloaded sign. Knee osteotomy is all about the position of the resultant vector, and we use the mechanical axis as a surrogate for the resultant vector, and the mechanical axis crosses the knee joint near the medial tibial spine. But there are errors, as Steffens just said. The X-ray must have the knee joint axis in the plane of the film, and the patella is usually in the center of the distal femur, but not always. And I've always had patients stand on one leg because that represents the mid-stance position of gait. And you look for the deformity then being in the femur, tibia joint, or a combination of one or all three. Our dilemma is that the L vector is completely unknown. The full direction and magnitude of the muscle forces cannot be determined clinically and really not experimentally very well. So we estimate. Now, we move the mechanical axis to a desired new location, and the potential error is, since we can't measure the vectors L and P, we don't know where the desired location should actually be. But a good estimate for a varus deformity is just with a mechanical axis inside the lateral tibial spine. And currently, most of us plan osteotomy just by moving the mechanical axis. But Margaret Beal recently published a paper in which she suggested it would be more accurate if we could calculate the external frontal plane lever arm. And to do that, she has a very complex formula which includes single leg stance, which she states is very important, the length of the tibia, the length of the femur, the width of the femoral condyles, the width of the pelvis, the width of the hemipelvis, and the distance between the center of the knee joint and the tibial spine. But still, there is no direct measurement of the muscle vectors, and so I'm not sure that this is all necessary. So how do we plan? On a single leg film, we draw a new mechanical axis, putting it wherever you want, but usually near the lateral tibial spine. Then you select a location for the osteotomy, and then you draw a line from the center of the talus to the apex of your potential osteotomy, and then it intersects the mechanical axis, and the angle between those two lines is your angle of correction. With a closing wedge, it's exactly the same. You measure from the apex of the your wedge to be resected, going from the old mechanical axis to the new mechanical axis. And the further the osteotomy is placed down the leg, the larger correction, of course, is necessary. Opening wedge, closing wedge, it probably makes very little difference in complications or outcomes. Here's an opening wedge on the left and a closing wedge 2 weeks out on the right. Now, there's a good paper from the Nijmegen group suggesting that the results were significantly better with the closing wedge technique based on their evaluations. It's just not as easy to obtain. we have to always look for a figure there's a hinge fracture. And in fact, the bone won't bend enough not to have a hinge fracture. I think hinge fractures are universal. We just don't see them. Here's a case, 65-year-old physician. At 12 months, he had a non-united tibia with aching pain. At 18 months, he was painless but weak. And at 13 years, he's able to comfortably run 10K. At surgery, it appears to be a well-done osteotomy, but at 6 months, we can see there was a hinge fracture, and at 9 months, we can see the hinge fracture is still there, but it did go on to eventual healing. Something we don't pay attention to is rotational deformity. And here's a patient that had an osteotomy with a 21-degree external rotation of the tibia. It appears reasonable on the AP, it appears reasonable in the lateral, but on the CT scan, which was done later, it's off by 21 degrees. He has resumed running, but his right foot turns out when he's run, which has resulted in an Achilles contracture, a posterior tibialis, a rupture, a hyperpronation of the foot, and here is running shoe on the involved side compared with this normal side. Now here's a rotational deformity of 25 degrees, which was done by an extremely well-known, talented AO osteotomy surgeon, and it looks very good in the AP, but it's 25 degrees off, and he had a correction. Tibial slope's a problem, maybe more so with opening wedge than closing wedge, but both possible. This is an opening wedge with a posterior slope of 26 degrees, completely unsatisfactory. Here's two not so common cases. This patient appeared in clinic and said, I saw you in 1981. You gave me great advice. I couldn't walk 100 meters without pain. I couldn't play golf. You recommended an osteotomy. I've been walking 5 kilometers every day, playing golf every day until about 6 months ago. I'm now 92. What can we do to fix this? Well, here he is in 1989. Now, here he is in 23 years later. He's in varus on both sides, obviously varus on both sides. He probably was undercorrected to start with. So what do we do at age 92? Well, the minimum I thought I could do to help him would be a uni. And 3 years later, he came back and he said, this is wonderful, do it on the other side. So we can always find a solution. Here's an interesting case. This is a 65-year-old, had to quit playing tennis. He has 16 degrees of varus deformity. He's got this big defect in his medial femoral condyle, which we can see here. Probably so we would call it an osteonecrosis. Here he is 3 weeks post-op, and here he is 4 years post-op. That huge defect in the medial femoral condyle has spontaneously filled in, and he's playing tennis on a daily basis. Now, outcomes, the literature over 30 years is always the same. The outcome is if you get the mechanical axis correct, you tend, without complications, you tend to get a good correction. Coventry reported a 3-degree difference in the final alignment resulted in a 31% difference in 10-year survivals. So he had about a 94% 10-year survivals if he was absolutely within a 3-degree target. Nothing has really changed. Standing on one leg with a mechanical axis near the lateral tibial spine should be the goal. Any other location is not predictably good. Precision is paramount, and there really is no such thing as Fujisawa's point, so don't aim for it. How good are we at reaching the ideal alignment? Well, Marty's series of opening wedge osteotomies showed only 50% ended with the desired correction, 31% undercorrected, 19% overcorrected. Van den Bempt did a systematic review of accuracy and found final alignment aiming at within 5 degrees target, only missed the target 33% of the time. But if they tried to get within a 3-degree target, the miss was 77% of the time. Indications for knee osteotomy: any unicompartmental pain due to mechanical overload from malalignment, age, severity of deformity, degree of deformity are not contraindications to osteotomy. And my rule is every knee complaint gets an assessment of alignment and always consider correcting the knee alignment first. So the requirements for success are a whole limb standing radiograph. Knee joint axis must be in the coronal plane. For radiographs, you must know if the deformities in the femur, tibial joint. Better fixation helps prevent loss of correction. Closed wedge and open wedge, no difference. Early active weight bearing and full motion help. Watch out for malrotation or a change in slope. Perfect alignment often is only reached in 50% of the cases, and hinge fractures are inevitable. So thank you very much, and we'll move on. Thank you.
There is an old school that says when you have varus deformity, the deformity should be corrected at the level of the tibia. When it's valgus, it should be corrected at the level of the femur. I would like to invite Professor Schroeter to tell us if he agrees with this statement. Thank you very much.
Thank you, Maurizio. So the next lecture is varus knee indications for distal femur and or double level valgus producing osteotomy. So learning objectives are at the end of the presentation. You should formulate a preoperative plan depending on the deformity, describe joint line, obliquity, describe different possible types of varus deformity. So history in osteotomies is quite old. So in 1880, Sir William McGeevan published a very great book, which is still as PDF available. And even in this book, he described correction of huge varus. And if you have a look in the text, then he described he performed in this huge varus deformity 10 osteotomies on each leg, which is amazing, especially if you think about the time he did it. So to do multiple level osteotomies, it's not a new story. It's very historically. So, and next good paper came out in 1969. Benjamin published a double level osteotomy in huge arthritis cases. So if you have a look at this amazing osteoarthritis, and again, if you look to the success regarding pain before the surgery, he had a pain level in the majority of grade 3, and after the surgery, they moved from 22 to 2 in this group. So you have a huge success regarding degrees of pain. So what is the rationale regarding osteotomies and multiple level? If you have a look to this huge OA and the medial OA, then if you simulate an open wedge HTO, you will end up with a medial proximal tibial angle of 99 degrees. So you think about if this is a good idea to do. So Sarah Chachela from Grenoble in France, he published and described, in this case, you will end up with huge shear forces. And a good paper from Japan, from Hiroshi Nakayama from this working group, he described in the element analysis as a joint line obliquity of more than a 5 degree ends up with huge shearing forces. And the question is this observation theoretical thinking is the same in the long-term follow-up. And Terachi from Japan observed in his analysis that patients with open wedge HTO and combined varus and distal femur had inferior results. So, and what's about double level osteotomies? If we have a look to this paper from Babis from US, from the Mayo Clinic in Rochester, he published amazing results after double level osteotomies. And if you think about a follow-up of 83 months, and just one case moved to the TKA, so a survival rate of 97%. So my personal experience in double level osteotomy starts already 11 years ago, and in that time we have a big approach at the distal femur, and we moved to the Tomofix blade in 2012, and in 2013 I moved to the minimal invasive technique, which was an amazing success regarding the early rehabilitation part. So, and then we published our analysis, and we have the same good result than the other colleagues. So what's about the joint line obliquity? So the Japanese colleagues, they analyzed the joint line obliquity, and they compared the open wedge and the double level. and they have a good joint line obliquity in a double level if they compare to open wedge, where they have a high joint line obliquity. Another review article summarized the publication of double level osteotomies, and the complication rates with 2.28% is quite low. So in our working group, we look for the work intensity and quality of life, and it can be restored. And if you have the red, it's compared to a general population, and the blue one is preoperative, and the green one is after follow-up. So and in this review, they define the criteria of double-level osteotomies in a review article. The problem is they did not read the paper perfectly, because these values are not correct percentage in this paper, although it was in a high-impact paper. So for example, my paper was not well cited, and the Crosser was not well cited too. So again, please read the papers correctly. So general indication should be if you end up with an MPTA of more than 95, if you simulate an open wedge HU, you have to think on a double level osteotomy, and the target should be 88 to 95 in the MPTA, and the MLDFA should be between 84 and 89 degree, and the mechanical tipperofemoral angle should be a little bit of overcorrection, which was already mentioned. So this nice paper from Germany, from Matthias Feucht, he described in the analysis the different types of various deformity, and you have there a look to the deformities. So just 28 of the deformities are just at the tibia, and 23 are the femur, and 4% are combined, and 45% they have no bony deformity if you think about the original definition. So if you have a look to this paper and you simulate just an open wedge, you would end up with a high MPTA, but you have a deformity at the distal femur. So most anatomical corrections you can simulate in a different way, and depending on the osteotomy and the deformity, you have ideal osteotomy. And especially you look to the second part, distal femur osteotomy. In 8%, you will have an MPTA below 90 degree, and you can correct it with the distal femur osteotomy. In the same case I showed you the slide before, if you go for just a distal femur osteotomy in a varus deformity, you will end up with a correct alignment, which you see right here. So my take-home message is high joint line obliquity leads to inferior results. 4 types of various deformities are described meanwhile, and deformity analysis is mandatory to plan the ideal osteotomy. So thank you very much for your attention.
Thank you very much, Stefan. I believe we are learning many interesting things tonight. So one of those is that necessarily something that you only have with tibial osteotomies, femur osteotomies, open wedges, closing wedges, and there are multiple things that you have to think into consideration, like leg length discrepancy when you decide for open wedge or closing wedge as well. So now I have to say we move on, and we're going to talk a little bit more about when shall we talk about replacements.
Thank you, Stefan. It's always wonderful to listen to you. HTO versus uni, just some random observations. There's no absolute indication for a knee osteotomy, nor a uni, nor a total. But I will start with this paper because it's very good, and Stefan was one of the contributors. It's looking at results of high tibial osteotomy in 533 patients, and they're looking at the Oxford knee score and comparing the age of the patients with the getting osteotomy and the severity of the joint changes obtaining osteotomy. And if we look at the ages, at each decade, the Oxford knee score is around 40. If we look at the classification from minimal joint narrowing to severe bone attrition, the same. The Albeck or the Oxford knee score is in the 40s. If we look to the literature, we see Galati had 45 and 40. 45 was if there was a neutral deformity, and 40 if the knee was in varus. Pandit, in 1,000 cases, had a mean of 41 on their Oxford score. Luscombe had an 39. Pandit uncemented was 39 and cemented was 42, and Gilmer was with the robot 39 and without the robot 40. So we can see that the scores after osteotomy are about the same as the scores after a uni if we look in the literature. Now, this is an interesting observation from Liebensteiner and group in Austria, and that is that medial unicompartment arthroplasty should be reserved for patients with complete joint collapse. In patients with preoperative complete joint space collapse, the clinical outcome was superior to that of patients with an incomplete joint collapse. That means if you had more than 1 or 2 millimeters of joint space, they did not have as good a result. The outcome depends on optimal alignment and is indicated at 5 years. The Oxford score was 45 with neutral alignment, but only 40 with the varus alignment. There's a computer modeling program that looks at unis, and they found that all unis, or they concluded on the basis of computer modeling, that all unis change the load distribution, increasing it in the lateral compartment more than a normal would be, and they change the stiffness mismatch in the knee so that it was always valgus, but they also had the same overload laterally if the varus exceeded 6 degrees. And the area of least abnormal distribution occurred when the alignment was between 0 and 3 degrees of varus. Oh, geez, what happened here? Is navigation helpful for uni? Gustavo Valenzuela looked at 129 of my cases, of which 58 were navigated and 71 were non-navigated. Here's one of the films that was studied showing pre-op and post-op in this one with a neutral final alignment. He measured the percentage of offset of the width of the tibial plateau from the midline. So in the navigated group, the average preoperative offset was 65% of the hemi plateau, and that was reduced to 18%. And in the non-navigated group, the pre-op average was 58%, and it was reduced to 26%. So we can see there was a small advantage in navigation, but certainly more time goes into navigation. Overall, the literature is clear. Neutral alignment or balanced loading is preferable. Well, what about constitutional varus in the proximal tibia? Well, varus cannot be corrected without an extensive releases of soft tissue, ligaments, or an osteotomy. So therefore, should we do an osteotomy before or after we do a uni or combine? We don't know. So the challenge we're facing really is the challenge that everyone's facing nowadays, contrasting kinematic or anatomic alignment versus mechanical alignment. And the goal really is mechanically perfect, but with the ligaments intact, and to obtain mechanical alignment with a varus knee without disturbing the ligaments requires an osteotomy. Whatever you do, don't stretch the MCL by pushing in a uni which is too tight. And if you have to release an MCL, you may not have a uni prosthesis that's thick enough to fill the gap. So that can lead you to the possibilities of doing a uni after an HTO. Now, unicompartment knee replacements after high tibial osteotomies. Again, Gustavo looked at, found some of my cases, and we looked at 3 separate groups. Unicompartment after doing an HTO that failed, a total knee after an HTO, and a primary uni. And we found that the Oxford knee score with a uni after an HTO was almost 44. The Knee Society score objective and the functional scores were the same. Oddly enough, the primary unis weren't quite as good as the uni after a failed HTO. So in conclusions, our findings suggest that a prior HTO does not affect the clinical outcome of a uni. The results for the patients who underwent uni after HTO demonstrated good functional outcomes after 6 years. Now, similar results have recently been reported, 2022, exactly the same thing. These findings reinforce good results reported with uni afterwards. Uni versus overall, uni versus HTO, a meta-analysis and systemic review. 15 studies were reviewed. It was concluded the HTO was slower to heal, slower to recover, but at 12 months, the recovery was equal. HTOs had better range of motion, and they stated subjectively that valgus HTO provides better physical activity for a younger patient, whereas uni is more suitable for an older patient due to the shorter rehab time and faster functional recovery. But in the final conclusion, we were unable to conclude that either method is superior. So then there's a question of uni versus total. And that's an extensive literature that I can't go into, but I would like you to consider Hooper's observation. His observation in the data was 70% of those patients playing golf before surgery never played golf after a total knee arthroplasty. Just something to think about. Maybe we really don't know how our patients are actually doing. This paper of theirs, they looked at patients under 75 and they compared low impact sports activity before and after a matched uni and total knee group. They looked at the percentage participating in sport before and after surgery, the number of sessions per week, the number of minutes per session, the number of different sports in which they participated, and they looked specifically at swimming, dancing, bowling, cycling, and golf. On average, activity decreased in all total knee patients after surgery and increased in most uni patients after surgery. So golf, if we look at the changes after total knee, for activity activity in golf, it dropped 70%. 60% did not go back to bowling. 50% did not go back to cycling. 30% did not go back to dancing, and 23% dropped from swimming. In contrast to the uni, where 100% went back to golf, 100% went back to golfing. 3 patients didn't continue bowling. 1 patient didn't continue cycling, and 3 patients didn't swimming. But in terms of the sessions per week, the total group dropped from 3 to 2, while the uni group went from increase from 3.2 to 3.4. The minutes per session in the total knee group dropped from 62 to 38, while in the uni group, it increased from 85 to 92, and 43% of patients in the total group had pain with activity compared with 24% in the uni group. So I caution all total knee patients that they may not increase their activity or return to sports. And in summary, there is no absolute indication for either a uni or a high tibial osteotomy or a total knee arthroplasty. There's no clear difference between HTO and uni. And for failed HTO, uni is an option, and unis are likely to be more active postoperatively. Thank you very much.
Thank you very much. It was very interesting to review this data. I would like to ask a question to both of you very quickly, a very quick answer. Do you think that patients that are eligible for HTOs are the same patients that are eligible for unicompartmental knee replacements? Do you think that we're dealing with the same pathology? Let's say both of them have medial knee pain. And my question would be, are we treating people with unicompartmental knee replacements that should instead receive HTOs, or in the other way around? Very quick answers from each one of you.
Oh, yeah, yes, for sure. For sure. It is remarkable how advanced the arthritis can be with variable amounts of deformity. after an osteotomy.
Mhm.
And the main difference for me is the anticipated time of recovery for the patient, because patients are able to be a little bit more functional, a little faster after a uni. But if I could talk someone into an osteotomy, I always would.
Thank you. Stefan?
In my opinion, the patient group, and some of them are the same, by majority are different patient groups, because we know, meanwhile, if the pain is level too high, so they are very limited. So we have better outcomes with uni than with HTO. But if we have not this huge pain level, then we have better outcomes with osteotomies. And regarding deformity, if we have a huge deformity, we can have very successful results with osteotomy. That's the reason why we have to analyze all these patients, and we know if you have a huge OA and we can restore the alignment with uni, then there's a good indication. And if we are a huge deformity and would end up with still the various deformity after uni, the osteotomy is more the advantage, in my opinion.
Thank you. I will quickly share my screen with you now, so I can show a few cases before we finish this session. We have answered some questions in the chat already. And if you have questions, please don't hesitate to present your questions in the Q&A box. I'm sharing some cases with you right now. So this is a case number one. This is a 52-year-old male who is military on active duty. He has normal body weight, very athletic individual, history of bilateral ACL reconstruction more than 20 years ago. And he has medial left knee pain, no instability at the time of his visit. And he came to me because he was told he would have to receive a total knee replacement. So these are his radiographs. When he came to me, you can see that he has evidence of a previous ACL reconstruction. This patient is very active. This patient is a military, and he says, my pain is medial. Quickly, if you look at somebody with this profile, do you think that this patient could belong to either one of these indications, unicompartmental versus HTO, or what would make you reflect about what's the best indication for a patient like this one? What kind of information you need to complement your assessment? So,
well, there is a joint space present medially, and we know we're beginning to know that results of the uni are not as good when you have a persistent medial articular space.
Correct. I agree with you. And we did the Kellgren-Lawrence evaluation for this patient, and I agree with you. We also, for every one of those patients, we have extremity alignment studies to make sure that we understand the deformity. In case the patient has deformity of the coronal plane, we would like to know where the deformity is coming from. In this case, there are 9.2 degrees of varus. The mechanical axis is deviated medially by 33 millimeters. There is a mechanical proximal tibial angle of 82.6 in a normal distal femur angle, in a normal joint line convergence angle. So basically, this is a varus coming mainly from the proximal tibia. And then there is an MRI that shows what's going on with this knee. And we always request MRI to understand better. You see, he has a medial meniscal tear. He has degenerative changes in the medial compartment. I will go quickly because of timing. But MRI should, in my practice, is part of my assessment. And I also scope my knee, those patients, to make sure that I understand what's going on. And here you can see the ACL graft. You can see the medial compartment. You can see the lateral compartment, patellofemoral compartment. Looking at those pictures, do you think this patient would be eligible for any sort of osteotomy? Or would you consider that, looking at the cartilage, this patient would better off be treated with a replacement procedure?
In my opinion, that is a typical indication for an osteotomy. The cartilage lesion is very limited, and there's not completely lost. And yeah, so I would recommend for this patient an osteotomy.
I agree completely.
So I appreciate thank you very much. So this is a summary. This is the alignment. I agree with both of you. This patient has a varus coming from the proximal tibia. And this patient has an overload to the medial compartment, and this is why he's hurting. So, and this is a very nice picture from Professor Lobenhofer that shows that if the deformity comes from the metaphyseal area of the tibia, if you correct with osteotomies, your joints are going to be parallel, meaning this is how you restore the mechanical axis, keeping your joints horizontal. So this is the day of this procedure when we did the osteotomy. We always like to protect the hinge with a K-wire. We always like to make sure that we calculate with a software. We do a biplanar technique, and this is what we did in the very end. This is the pre-operatively, this is post-operatively. We were able to bring this mechanical axis to neutral, and this patient is doing very well and very pleased with the outcomes. So the message would be, if you have varus with abnormal MPTA, normal MLDFA, good range of motion, very active individual, valgus producing higher tibial osteotomy could be a good option. Everybody in agreement?
Yes.
With this message? Good.
Yes.
So I go to, yeah. Second case is a different one, 69, farmer, very active, on his feet 10 hours a day, medial knee pain, and this is how it looks like. So it's a little different situation now. He has joint space narrowing. He really hurts bad during the day. He's very limited, and this is what I normally do. I like to stress the knees and make sure that I can check the joint space and see if they are symmetrical when I can correct varus, in case they have varus deformity coming from the joint. Do you agree with this assessment, or you don't think it makes sense?
Yes, I agree.
Yeah. And then, again, when you run the software to understand where the deformity is coming from, you see it's a normal lateral distal femoral angle, normal mechanical proximal tibial angle, but he has an abnormal joint line convergence angle, and he has 4.8 degrees of varus. It's not a big varus, and to me, this is a candidate that has medial pain, arthritic knee changes in the medial side that are confirmed with MRI. And again, if the deformity comes mostly from the joint line, this potentially could be a case that could be helped with a unicompartmental knee replacement. And this is what we've done for this one, trying to bring this joint some level of comfort and balance and keeping the mechanical axis neutral. To me, and I would like to hear from you, if mechanical axis matters when you do unicompartmental knees, especially when you indicate unicompartmental knees. What's your opinion about mechanical axis? How much of varus preoperatively would you accept to do a unicompartmental knee replacement? Or would you accept a unicompartmental knee replacement for somebody that has like over 5 or 8 degrees of varus?
In my opinion, I would, what you did, simulate with stress X-rays, if you can realign the leg with the stress X-ray, and then at the end, I would like to have a more or less straight leg. I know in the literature from the Oxford group that it doesn't matter regarding the outcome if you end up with a varus. So the Oxford group recommend even in huge varus deformities you can put a uni in, but I would like to have more or less a straight leg, and in the huge deformities, then the osteotomy could be better. So in this case, you have no bony deformity, and I would exactly do the same, because you have the patient complains on a high level of pain during the day, and he is active. So I would do exactly the same. But so come back to your question, my limitation would be after uni, I would not have to more than 3 or 4 degrees of varus. That is really the limitation, in my opinion.
Bob?
Yes, I agree. I would consider osteotomy in this patient, but at age 69, and returning to activity, I would do a uni. And the goal for osteotomy would be a near neutral alignment, which relative to the mechanical axis is 2 degrees of varus.
Thank you. So let me go again. This is a varus knee, but the varus came from the joint and the pain was significant. And I believe this is a good indication for uni, considering level of activity, group age, expectations of the patient as well. This is a case that I shared with most of you, and this is what I want to share with you today. This is a 47 that came to me also saying I had medial knee pain. My pain is excruciating. I cannot stand on my feet all day long. I have to work every day and I can't. 35 years ago, I had a pathologic fracture of my distal femur. I was treated when I was a teenager. I don't remember exactly what happened to me, but I'm interested to get a total knee replacement because I cannot handle this pain anymore. This is the patient in clinic, the physical exam. You can see right lower extremity. He also had some shortening of the right lower extremity. When he walks, you're going to see the varus. You're going to see that he limps. And he is very athletic, and he performs a lot of things on a daily basis, but he really cannot tolerate his pain. This is the motion, and this is when the patient lays on his side. You can see the varus that he has. And the range of motion is very good. I believe it's a good thing to consider as well. Then, if you look at the x-rays, there is a distal femur deformity, like a malunion of the distal femur. And now, when you come to the mechanical axis, it's a lot of varus there. And I ended up using the software, and he had 15 degrees of varus. If I would try to go and correct on the femur, saying, okay, he has a malunion, let me see what happens if I simulate the correction of the femur, I can always bring the mechanical axis to the center of the knee, but the joint line is going to be oblique. And you can see that the joint orientation angles in this case are completely abnormal, all of them. This is, to me, what matches what Dr. Schroeter said about planning a double level osteotomy to distribute the correction, also trying to see what's the best alternative to adjust leg length. In this case, this patient was 2.5 centimeters short. And I said, if I do double level osteotomy with double open wedge, I will break even with the leg length discrepancy. And I could calculate this with the software as well. This is another way to calculate if you're going to use open or closing wedge, paying attention to the leg length discrepancy. So these are the osteotomies, and this is what we've done. It's a biplanar on each site. This is after healed, and you can compare the alignment now. And this patient has an horizontal joint line, but also pay attention to the pelvis. He no longer has a pelvic obliquity because his leg length discrepancy has been addressed. And the joint lines are horizontal now. Right. So my question for you would be, do you think that a double level osteotomy is a procedure that you can pursue even in individuals that have tricompartmental arthritis? Like this individual had tricompartmental arthritis, but I consider that he was too young with very great range of motion, very high level of activity. And looking at the data that Bob presented about level of activity after total knees, I said, I should have to try to preserve his joint. I would like to get your criticism on this one, if you would do the same or if you would consider a total knee.
I'm sure Stefan agrees. Definitely osteotomies. And I'm not worried about tri-compartment disease unless I can prove that there's pain coming from one of the other compartments, which is not always easy. There is a test that I use routinely with all osteotomies, and that is I have the patient stand on one leg, leaning against the wall while I apply a thrust to push them into valgus, and then have them do a squat in that position. And if the pain's relieved, then for me, it's 100% osteotomy.
Very good. Thank you.
Um, I I completely agree with your procedure, and in my experience, even in severe OA and huge deformities, the patient improve amazing way after a deformity correction. And sometimes in these huge deformities, post-traumatic or the congenital, some of them even complain lateral pain because of the stress of the ligaments. So you have to be very careful in analyzing your case, because sometimes the patients say, yeah, and I have pain even lateral, and then a lot of colleagues say, okay, that is not a case for deformity correction because he already complains in all compartments. But you have to think about if the pain coming out of the joint or from the stress on the ligaments because of huge various deformities. So I completely agree at first, looking for the alignment in these cases. And you cannot correct it in a proper way with a TKA because it's after this pathological fracture, it's an extra-articular deformity, not an intra-articular deformity. And if you be aware on the CORA rules, and if you correct it with a TKA, you have probably a problem to straight up the leg with a TKA and the insertion of the ligament. So although or even if you would not be happy with the result after 5 or 10 years, now you have a horizontal joint line and you can easily put a TKA in. So definitely the correct indication, in my opinion.
Thank you. I will go quickly because, go ahead, Bob.
I agree completely, absolutely with Stefan, but sometimes a patient like that will appear with lateral pain rather than medial pain, and it then is the traction on the lateral side that they're noticing more than the medial arthritic pain.
Thank you. I will go very quickly so we are getting close to the time when we should wrap up this webinar, which has been very interesting. So now I'm going to show you a very quick case. For a case like this one, which is no longer a medial knee arthritis, but this patient came because of medial knee pain. And if you look, there is subluxation. This is a tricompartmental arthritis. And you see the alignment study is even hard to do because the patient does not fit to the picture because it's a severe varus. So there is no discussion that those cases, no doubt, it's very unlikely that you can please a patient with severe pain. These patients also have limitations in range of motion. And for those patients, I believe that a total knee replacement would be a right call if the group age and biological age matches, also level of activity expectations. I'm just showing that the alternative is not just going to osteotomies all the times, but there are multiple situations when osteotomies make a lot of sense and could buy a lot of time before a total knee replacement could be performed, or even improve alignment prior to a total knee replacement, as Dr. Schroeder mentioned. So let me conclude. Let me just say the main goal of this webinar was to show you that there is a broad spectrum when individuals come to you with medial knee pain and when they have varus. And there are multiple procedures you may consider to do, from joint preservation to joint replacement. If you understand the alignment and if you pay attention to the patient's complaints, level of activity, expectations, what the patient wants to do, it helps you to decide if an osteotomy makes more sense or if a knee replacement, uni or total, would make more sense. In summary, you should go where the money is. And as has been presented today, there is a lot of data in the literature, but we're still missing some details that sometimes the literature does not reflect, like the small things that happen in the daily living and what the patient wants to do. So before we go, I would like to say we are always available and happy to answer questions in case you have any. And also, I would like to invite you all to this course, which is an in-person course in Florida. Happens in February. It's an advanced level. We're going to have 5 practical exercises with ligament surgeries there in artificial models. We're going to have outstanding faculty group. And because AO Sports wants really to spread this message around the country, we really would like to invite you to come, and we are offering spots with discount. So if you're interested, go to the webpage of AO North America, AO Sports, and consider to register to this course. And before I go, I'd like to say, to do a meeting like tonight, there are many people working behind the scenes. I would like to thank AO North America and their staff for the phenomenal support and work in order to allow us to put this together. I also would like to thank my colleagues who did an outstanding job presenting data and their experience. They're very experienced and very respected surgeons. Professor Teit, it's an honor to share with you tonight. Professor Schroeder is the same. Professor Schroeder, it's morning for you in Germany, so it makes it even more special to see how much of passion you have to share your ideas with all of us. Thank you very much. And I hope I can meet you at some point in the future, maybe in Florida during the Advanced course. There are more questions in the Q&A that I promise to answer via email as soon as we can, because we're getting close to the end of the time. If no more, any final comments from you, Dr. Schroeder, Dr. Teit, before we go?
Well, thank you very much for the, sorry, Bob, go ahead.
I hope you get some sleep tonight. Thank you very much, Mauricio. This is, I think you did a great job.
So thank you very much to the whole audience that you stayed with us for this webinar. It was a big honor for me to be part of this webinar in the AO North America. So thank you very much.